I'm privileged to introduce my Guruji, Dr. Sapan Pandya sir on stage in his own style. સાહિત્યના જીવ એવા અમારા સૌના માર્ગદર્શક એસ ફોર સપન પંડ્યા સાહેબ કે જેમનો એસ ફોર સાયન્સ સાથે ખૂબ અતૂટ નાતો છે. એસ ફોર સિંગિંગ એમની હોબી છે અને એસ ફોર શોગરેન સિન્ડ્રોમ જેમનો એરિયા ઓફ ઇન્ટરેસ્ટ છે. સર આવો એસ ફોર સૌરાષ્ટ્રમાં આપનું સ્વાગત છે.
Respected chairpersons, thank you Mayank bhai, Milab bhai, Sanjay Bhatt, Gunjan Joshi, all the organizers for the honor. It's almost 1.5 to 2 years before which I came here, so thank you. અને તે મને હવે કીધો જ છે આર્ટિસ્ટ, તો પછી I'll start with some art. કે નસ નસને રોમ રોમથી થાકી જવાય છે, નસ નસને રોમ રોમથી થાકી જવાય છે. મજાની એ વાત છે તો બી જીવી જવાય છે. અને વરસાદ બી શું કરે ને છત્રી બી શું કરે, બીજાને કોરા રાખવામાં સારું પલળી જવાય છે. So with that, it's always an honor to come here. Before I start my talk, and Shabir, please remind me because I keep talking, when I'm 5 minutes before the time so that I know that I have to stop. I'll tell you the real life story of how important is immunosuppression to physicians and to us, not just because of side effects. જામનગરથી એક પેશન્ટ રેફર થયું હતું મને. This is about 10-12 years back. Maybe I was one of the few rheumatologists then. અને referring physician એ મને લખેલું. He was also in Jamnagar Medical College. And I always have a greater respect for college in some way, I don't know why, for academicians. So he was also, and he wrote to me કે સાહેબ anca vasculitis લાગે છે, તમે જુઓ. And the patient had diarrhea and bleeding, PR severe. And I was in a small setup. If you guys would know, Shreya Hospital માં હતો એ વખતે, અને gastroenterologist available હતા મારા બહુ સારા જાણીતા નિષ્ણાત. I asked him to see, and he put the scope and he said, this is pancolitis for sure. So I said, okay, pancolitis છે તો હવે મારું તો બહુ કામ છે નહીં, અને તમે ટ્રીટમેન્ટ આપો ને. I had given methylpred bolus obviously before because she was bleeding. And I sent back the patient to the physician. The same patient came after 1 week to 10 days with massive bleeding again. And she also had a history of asthma and eosinophilia. So which, and I referred to the gastrosurgeon now, and he opened it up. Chavda opened karyu, Hitesh Chavda, and he called me up and said, there is hardly any normal intestine left, Sapan. I can't do anything with this lady now. We sent it for histopathology. It was EGPA, which was called Schurg-Strauss vasculitis. I went back and reviewed literature, and there were at least 8 to 10 case reports of EGPA presenting with ulcerative colitis-like manifestation, which I did not know at that point of time. The message was, I don't know if the patient would have survived or not, but I should have given the patient cyclophosphamide at least, then which was available 10-12 years back. So at least મને અત્યાર સુધી patient યાદ છે. I remember that lady. The physician was Dr. Tarak Shah, who was one of the very good physicians, I think, of Jamnagar, and he had referred to me with the correct diagnosis. 2 messages here. One is that it is not always the specialist who knows stuff. There are good physicians, there are very good physicians who refer you. So remember that always. I learned that day. And second thing is, it's not always about the side effects and adverse reactions. You also have to give immunosuppression in time to save patients. So that was the message from the story. I'll begin there and go on with my talk. So another good line that I read from one of our very informal journals called Rheumatologist, that an expert clinician is a physician who has a depth of experience, is extremely intellectually curious, is adept at truly listening to patients, demonstrates empathy, understands the science underpinning key concepts in medicine, is up to date on current therapeutics and research, and is honest about what he or she does. This sums up so well what we should all be doing actually. So I just thought I'll put it here. This is the outline of my talk, and so that was before, this is outline of my talk, list of drugs, indications, individuals. I just have 1 or 2 slides of each, not more than that, and then the takeaways in near future. This is just to again remind me of a case which we had, was a recent case of lupus, severe nephritis with diffuse alveolar hemorrhage, and she was admitted, and for almost 10-15 days, and both me and my colleagues tried to treat her. We eventually lost her because of infection, what looked like an infection. So the problem with immunosuppression, we gave cyclophosphamide and rituximab and all of that, but she still did not survive. And this is the story of another patient which Kunal had successfully, my colleague who's come from Ahmedabad, was a young lady with macrophage activation syndrome, and she survived, and she is now back to Delhi where she came from with the immunosuppression. Just to say that you have to be aware of both the adverse effects and the advantages of immunosuppression, which you have to know and give them. So this is the list of drugs that, what are the principles of therapy of rheumatologic disease? Symptomatic treatment and disease modification, preventing complications. And this is the various list of drugs that all of you know we use in various doses in our different diseases. So what are the kind of treatment? The treatment would depend on what the problem is. So this is a young lady with this kind of joint pain and swelling which comes and goes. It lasts for 1 or 2 days and then goes away, which is called palindromic rheumatism. Now you usually would just give hydroxychloroquine or NSAIDs for this. You may not need very heavy immunosuppressives. I'm just saying where we use immunosuppressives and what we give. This is, for example, a patient with sacroiliac pain, and on the MRI you just see here bone marrow edema. Again, normally we manage such patients with just NSAIDs, or so this won't require much of immunosuppression. On the other hand, if you have such florid inflammatory polyarthritis of even 4 to 6 weeks duration, most of these patients would need some kind of immunosuppression form of methotrexate or sulfasalazine, hydroxychloroquine, or various combinations, and even low dose steroids. Lupus would mostly, this is one of my patients with lupus GI mesenteric vasculitis. You can see the thumb printing here, the bowel lumen, and so these are patients who would need cyclophosphamide or steroids or those kind of immunosuppression. Again, dactylitis would usually need some kind of disease modification which is acute. You may start with an NSAID. So different levels of immunosuppression and disease modifying drugs. Again, interstitial lung disease, I think Harjeet just talked. He gave the names of rituximab and other drugs which I use now. This is vasculitis, rheumatoid vasculitis. Again, would need immunosuppression, corneal ulcer, peripheral ulcerative keratitis, gangrene from vasculitis. All of these would need heavy immunosuppression in the form of steroids or cyclophosphamide. So depending on whether it's an organ-threatening condition or not an organ-threatening condition, we would use and that is part of the art of medicine. So what is immunosuppression really? So the definition of immunosuppressive effects of low and high doses. Less than 20 milligrams, so more than 20 milligrams per day for more than 2 to 3 weeks would qualify for heavy immunosuppression in the case of corticosteroids, prednisolone or its equivalent. Methotrexate, તમે 0.4 milligram per kg, 50 kg નો માણસ વાળા તો 20 milligram આવે. So what we use is very low dose actually, low dose methotrexate. Oncologists, use, and I was trained in hemato-oncology, so we used to give 100 milligrams of methotrexate to children with ALL. I don't know if that's still the protocol, but that's the dose we used to give. Azathioprine, so we are not really using very high doses, but you still have to know so any kind of tofacitinib becomes a high dose immunosuppression, biologics become high dose. But rest of them are, so depending on the high dose or low dose, you would have those kind of infections. So I've just dotted down what is important, I thought, from the practice point of view. કારણ કે આ એટલો vast topic છે ને કે આમ તો પતે જ નહીં. So all the lines are probably going to be important for you in clinical day to day. So equivalent doses of glucocorticoid is a disease modifying drug. The Cochrane analysis of 2016 confirmed that. And prednisolone 5 milligram is equal to 20 milligrams of hydrocortisone, is equal to 0.75 milligrams of beta dexamethasone, is equal to 6 milligrams of deflazacort, is equal to 4 milligrams of methylprednisolone. So you have to know the equivalent doses of prednisolone and the various corticosteroids. Deflazacort is not superior. So I've been very frequently asked these questions, and people use deflazacort or not. On the contrary, the absorption is sometimes erratic. So I would prefer simple prednisolone in most cases. Dexamethasone cross the placenta, and therefore you give it in those patients where you need it for pregnancy, and preferred for CNS because it also penetrates the CNS. Why methylprednisolone acts immediately is because of you have the genomic effect and the non-genomic effect. So the non-genomic effects is through the receptors on the membrane. And when you give high dose of methylprednisolone, it saturates all the receptors on the membrane. That is how it acts earlier than the genomic effect, which will take 2 to 3 weeks. So that is why you give methylprednisolone boluses when you want early effect. Remember, bone loss begins from the first dose itself. So there is no safe dose of steroid as far as bone loss is concerned. AVN can happen with a single methylprednisolone bolus. So there are probably genetics to it which we haven't still found out. And so this is the bone loss that happens with various doses of prednisolone, and that is why the American College of Rheumatology actually recommends giving bisphosphonates if you are to give more than 0.75 milligram for more than 3 months of prednisolone or equivalent. Coronary artery disease is certainly more when you use prednisolone than you don't use in patients of most of our diseases. So again, that is an important side effect. Coming to methotrexate, remember it is still the anchor drug. So all of recommendations, that second line, are after you use methotrexate in patients of rheumatoid arthritis, and preferably parenteral. So you first give oral, then you use parenteral, injectable, and if that doesn't work, then you go to a second line drug for rheumatoid arthritis. Adenosine release is the main mechanism, unlike what we thought that dihydrofolate reduction is for, but this is an anti-inflammatory sort of chemical. So not approved for pregnancy. Nausea and vomiting are, and transaminitis is central, so you can use either split dose or you can give an evening dose, try antiemetics or shift to injectables. Combinations are safe long term. People have used leflunomide plus methotrexate, sulfasalazine plus methotrexate, even tofacitinib with methotrexate. There are infections, mostly cell-mediated immunity. We know about these, and an occasional patient you will see who gets infected, but otherwise it is reasonably safe. Adenosine release is the main mechanism. For postgraduates, if there are any, that for your MCQ. And this was a study in compliance long back, and they showed that methotrexate was patients were most compliant with methotrexate than with other drugs. So it also happens to be the most compliant. Coming to leflunomide, efficacy spectrum is very similar to methotrexate. It acts on the proliferating lymphocytes by inhibiting the dihydrofolate reductase. Can cause, so this was one of my patients who died of, not my patient actually, had gone to see, and this patient severe oral mucositis, and मैं ना prescription मैंने आज हूँ जीवराज मेहता में जो गया तो early days of my practice, and I asked for the prescription of leflunomide, and he said we haven't. I said क्या कापू तुमने अपाई हुआ है? Then I saw Lefra was given, and the right doses, and actually by an orthopedic, and she had jaundice. Patients of leflunomide with TEN or SGS with jaundice usually don't make it. And I told the son, okay, it's going to be difficult, we'll try, give cholestyramine. महीना પછી patient ना छोकराનો phone आयो हमारा clinic पर, and I said no, I'm not talking. Please don't connect me to him, because I thought he might, do something wrong to the orthopedic maybe or whoever. He came to my clinic 2-3 months later, and he said કે સાહેબ તમે photograph લીધો તો મારા મધરનો હાથનો અને ફેસનો, because she had mucositis. And he says, we don't have a photograph of hers for the last 1 year, so can you just share that photograph? He wanted the face photograph. So how patients, how you learn humanities with practice. So this was one patient who had died. So they can die, and I have seen at least 3 deaths with leflunomide. Avoid in childbearing age group. It has a long half-life. Combination with DMARDs, biologics and small molecules have been used. And when you have a slightly raised creatinine or a slightly low GFR, leflunomide is the preferred, because the oral prodrug of leflunomide was actually from renal transplants. Was used in renal transplants. This is the leflunomide plus methotrexate, so it is safe it can be used. You have to monitor the liver, of course, enzymes. Coming to azathioprine, inhibits purine synthesis. The anti-arthritis effect of azathioprine is not great. So we would use it for, hematological conditions. Even in interstitial lung disease, as Harjeet pointed out, MMF has now become mycophenolate has become the drug of choice compared to azathioprine. But we use it as a steroid spare in other drugs. You know about these assays which ideally should be done before you give azathioprine, but there are problems to that. So and it's a costly test, so if it's not very affording, we still use the conventional 50 milligram per day for 7 days, pasi test karao, પછી પાછું બીડી કરો, પછી પાછો ટેસ્ટ કરો અઠવાડિયા પછી કે સાયટોપિનિયા નથી. That is the way we monitor. Approved in pregnancy, so can be used, and as a maintenance in lupus nephritis, it is good. Not as induction. Remember, induction lupus nephritis has to be with mycophenolate or cyclophosphamide. And there are drug interactions because of the inhibition of xanthine oxidase by both allopurinol and febuxostat, which increases the prodrug of azathioprine and leads to fatal cytopenias. Mycophenolate inhibits inosine monophosphate dehydrogenase. Higher doses are useful. Actually, interstitial disease, the dose recommended are 2 to 3 grams per day. હવે આટલી મોંઘી ડ્રગ ને આટલા હાઈ ડોઝમાં યુઝ્યુઅલી પેશન્ટ નથી લેતા. That is one problem due to cost and gastric problems. It has to be given on empty stomach, avoid with antacids. There used to be some data on different trough levels which you used to do before, but now that's no longer done. Different ethnicities have different trough levels. And it came from transplants, is used for induction therapy of lupus nephritis. And after the scleroderma lung study, it is somehow the drug of choice for every ILD. So from scleroderma, we have taken it to rheumatoid and other. So we use mycophenolate mofetil in ILD. Can be used in combinations, but can't use in pregnancy. That is cyclophosphamide is a intercalator. Oral now is seldom used. So some of the older generation physicians still used to give oral cyclophosphamide. Oral cyclophosphamide is a very effective drug. And some people still believe that in vasculitis you should give it, but most of us now don't use it because of bladder toxicity mainly. Induction therapy, lupus nephritis, and ANCA-associated vasculitis. And my nephrology colleagues, જ્યારે MMF mycophenolate નવી આવી હતી ત્યારે એ લોકો કહેતા હતા કે it doesn't seem to be as good as cyclophosphamide, and we rheumatologists did not believe them until we ourselves saw that I think they have a point. And I think cyclophosphamide still works better than MMF. If you want to use mycophenolate, you combine it with tacrolimus as induction therapy, and that works. Bladder toxicity, gonadal toxicity, all of us know. But it is overemphasized, so you can use it safely up to at least 3 grams of cyclo. That shouldn't cause problems. Cytopenias, it is not myeloablative, so it's a bone marrow suppression, not permanent, can cause infections and second malignancy years later. Again, as you can see in ANCA-associated vasculitis, many of us would still prefer cyclophosphamide even to rituximab if you have RPGN, rapidly proliferating glomerulonephritis, or diffuse alveolar hemorrhage. When you want a quick effect, you use cyclophosphamide, not rituximab. Calcineurin inhibitors, cyclosporin versus tacrolimus. There are advantages of tacrolimus in terms of cardiovascular effects, dyslipidemia, hypertension. Otherwise, and it's more on a weight by weight basis, much more potent than cyclosporin. This is a new drug, which is the Aurora trial, which is, I think, soon going to come in the market for lupus nephritis. Renal, I had a patient who died of press because of cyclosporin. So posterior reversible encephalopathy, you have to remember that. Induction therapy, useful for refractory rheumatoid, ILD, myositis, and for aplastic anemias. Pregnancy, it is approved, so you can use it. Rituximab is a B-cell depleter. There are type 1 and type 2 depending on if it complement-mediated cytotoxicity is a mechanism that is used, or ADCC is the only one. This was last week, this Thursday in NEJM, the newer obinutuzumab, which is a type 1 rituximab, B-cell depleter, and they found it has greater tissue penetration and better results. It is drug of choice for PR3 ANCA-associated vasculitis, GPA, and maintenance. Maintenance, it is certainly proven. In induction, some of us might still use cyclophosphamide. Lupus open label trials, the randomized trials are actually negative, but then there is a lot of open label data and we still use it. And in many other conditions, rituximab has almost replaced high dose of steroids in most of our conditions, at least those which are antibody positive and are B-cell mediated diseases. You have to look at the globulin levels. Not all of them get infections, even if the globulins are low, but you still monitor those. And the vaccines, especially the pneumococcal and influenza, has to be given at least 1 month before rituximab to have its effects. Hepatitis B is a problem. You don't give rituximab if they are Hep B, active Hep B positive. Sorry. Anti-TNF therapies, we know the drugs names, all of these are available in India. Useful for arthritis, especially seronegative RA. These are the other conditions. In Takayasu, it is used as second line after steroids. It's actually recommended before IL-6 inhibition by the American College of Rheumatology. Refractory pyoderma gangrenosome vasculitic ulcers and deficiency of adenosine amylase 2 Again, TNF is the drug of choice. Avoid with interstitial lung disease. There was some recent data where it showed that it doesn't worsen that much, but still, most of us would not give when we have interstitial lung disease. It can be used at least in the first 2 trimesters. In the last trimester, you might want to avoid it, but you can still give it if the disease is active. These are the various side effects of anti-TNF therapies, predominantly being tuberculosis in our country. You can get demyelinating diseases and some other problems with its use. Tocilizumab became famous after COVID. Anti-IL-6 is a pleomorphic cytokine, subcutaneous and intravenous formulations, both are used. Only biologic that can be used without methotrexate. So this is the only one approved without methotrexate. These are the various conditions. We usually use it for macrophage activation syndrome because it's a costly drug. And when rheumatoid doesn't respond to any drug, somehow it seems to respond to tocilizumab. And in scleroderma ILD, it has now come as first-line therapy, which actually surprises me. I'm not very impressed with the data, but I don't know why it is still there. Efficacy better than biologics. Compliance too is more with tocilizumab. They have found these studies, and there are problems with cholesterol, but it is a good cholesterol which rises, so the ratio remains the same. Infections is a concern. This is tocilizumab in ILD, and you can see that the benefits are more than with placebo. Jacnebs, which has somehow become the favorite, and we were just discussing that there are some rheumatologists like me who use it very much. But it's a difficult drug when you get infections. Advantage in pain relief. So there is a relief in cortical sensitization, so it helps the pain. These are the conditions where it is used. Herpes is a problem. Major adverse cardiovascular events, malignancy and infections. This was one study which showed Barry was actually better than adalimumab. I won't be discussing ecortimod and apremilast, not used very often. They fall into immunosuppression, but we don't have time. So coming to the last part, this is going to be the future, bispecific antibodies, bispecific T-cell engagers, and CAR T-cell therapy. I hope you have a session on this by hematologists, and this is going to be the future of immunosuppressive therapy. And these are the differences. By CAR T probably cures. It can cure, bispecifics may not be able to cure, but there are some differences between the two. So the takeaways are immunosuppressive agents have improved survival and quality of life in patient autoimmune rheumatic disease over decades. Level of immunosuppression is decided based on the severity of illness and if it is organ threatening or not. Infections remain the main complication. Physicians have to know about the adverse effects of these agents as they would be the first to see these. So that's very important. And while knowledge about these drugs is a science, its use in day-to-day practice and individual patients is actually an art. And this is a line I read in one of the blogs. Often in medicine, especially in academic training, we forget to ask our patients, what do you want? What brings you to us? How are you feeling today? It's a question answered and forgotten, an item to be crossed off during our history taking initial assessment. A part of our rounding vitals, it is time to realize that their questions are as valid as ours. At the end of the day, ours is a brand that does not only include pathological diagnosis, but a person at the peak of vulnerability that has come to us for aid. If we cannot at least offer our support, or even at most sometimes just offer to listen, what good are our solutions? And just how much water do they hold in their lives? I think it is very important that we have a shared decision with the patient and also look at what they want from us. Thank you.